Well, welcome. Today we're very excited to have Shamez Ladhani, Dr. Shamez Ladhani on. Dr. Ladhani is a pediatric infectious disease specialist at St. George's Hospital. He's also an epidemiologist, and he's really an expert on vaccines as well. Dr. Ladhani, thank you so much for coming on.
Thank you very much for inviting me. It's quite an honor.
Dr. Ladhani, I did not do you justice in my one-line introduction. So tell me a little bit about what does he do? I know you're a pediatric infectious disease specialist. You're at St. George's Hospital, but then you have a couple other hats you wear as well. So tell us a little bit about that.
So it's a little bit of a mishmash job that I had before. My interest is in vaccine preventable diseases. So I do look after children with complex infections in the wards. And at the same time, I work in the university where we do clinical trials, a lot of trials on vaccines in children. And then in public health, I lead on a number of national immunization programs before this pandemic. So it sort of keeps me in balance because it gives me a frontline view of what's happening in life out there, and at the same time help guide national policy on vaccinations.
Wonderful. What have your thoughts been on the conversation on risk from COVID to children? How do you think medicine has done? How do you think the media has done so far?
It's actually a very deep question, that because as a pediatrician, my interest was always in children. So even at the start of the pandemic, when all my colleagues were working on adults and elderly and hospitalizations and so on, I think me and a few other pediatricians I work with realized very quickly that at some point, this is going to filter down to pediatrics once the adult situation is sorted. So we started working on pediatric COVID right in the beginning of the pandemic, setting up different surveillance programs. And we quickly understood that this is going to be a virus that is going to remain in children for a very long time. We just didn't know which direction it would take. Very early on, we realized that this infection may be mild in children, as many other respiratory illnesses, but they do form quite an important part of the community. And there were always going to be concerns about transmission and closed settings, such as schools, where you could potentially get a lot of infections that could then filter into the community. So even though they really didn't get much attention at the beginning of the pandemic, we quickly realized that they are going to be an area which is always going to be contentious. And when all the attention was focused on the adults, very little attention was paid on the kids. And we had a very different role at the time in trying to support the kids because of the disproportionate effects that the kids were having early in the pandemic. And that was a very different phase of work that we had to do, because we were concerned about the school closures, the indirect impacts of social isolations, the lack of contact with other children. We quickly realized that education, going to school is not just about education, it's a lot more, because they were missing out on their physical, emotional development. We have a lot of immunization programs that are school-based as well, which was taking a hit at that time. So there was a lot of focus in trying to push children back to normality, because the harms of social isolations were far greater than the concerns we had about the virus.
Shamez, it seems like a very different attitude from what we see on this side of the Atlantic. You talk about we, meaning you have different perspectives. You work with people who look at the global picture, as opposed to just you being a specialist in infectious diseases and just worrying about this thing. And then, do you get a sense, or how do you account for that? I mean, are you are you part of a team that, I mean, from just naturally you think about globally what the impact is going to be, not just on the infection that you're at hand, but on everything else as well. I mean, I find that remarkably good.
So I think one of the advantages I have is I have a very established post in what used to be Public Health England, which is the National Public Health Centre for the UK. And I was one of the rare breeds of pediatricians over there. So I made sure that over the last 10 years or so, anything to do with pediatric public health and vaccines actually come through me and my team, because we have specialist interests and we also have frontline links. And the work that we started right at the beginning was at a national level, having the advantage of having access to national data and national surveillance. So we very quickly were putting out the message that children were protected from the virus and they were less likely to get sick. We were able to compare rates in children and in adults. We looked at hospitalizations, and our primary aim was to emphasize the less severe nature of the infections in children. We also started noticing very quickly that the harms that were being done at a national level. And I have various hats. For example, at the time I was leading a national surveillance unit for pediatricians, and we were very quickly able to put out information about the late presentations of children to hospital because parents were told to stay at home and they were scared to go to the hospital. And what was happening is we were getting a lot of children who were coming very late with very common illnesses and ending up very sick. And unfortunately, some of them dying as well. So by collecting information in real time, we were able to influence national policy and government messaging. So the stay at home quickly changed to stay at home, but if you're unwell, the healthcare service is available to you. The second concern we had, for example, at the time was schools, and people were concerned that when children go back to schools, you're going to basically cases will explode into the community. So we quickly set up surveillance in schools. And what was funny is that actually by virtue of the work we were doing, others became interested in what they were doing. So I am not very prominent. I'm not very well known in the wider field. I do a lot of work in pediatric infections, and people know who I am, but not in the wider context. And COVID was always new. But what you do get is suddenly the educationalists were interested in the work we're doing in schools, for example. The Royal College of Pediatrics understood that there was important messaging coming through from the work that we're doing about children's safety and returning back to school. So they linked up with the work that we were doing. WHO started writing guidance on children, and they also started noticing and then coming to us for more information and input and experience. So it was a very unusual experience in that by just doing what we thought was important for our kids, it was gaining attention out there that allowed the message to be spread wider.
Was it pretty clear to you early on in this pandemic, almost 2 years ago now, that the risk to children was relatively small? Is that something that based on data or based on just, you're obviously a pediatric ID doc at a pretty major hospital. So, you have your anecdotal evidence obviously carries a lot of weight compared to many. But was it a mix of data plus anecdotal evidence, your experience that suggested that the risk to children was pretty low?
So it's a really important point that you make over that, because we never assumed that children would be at low risk of infection. They just didn't get very sick with it. And I work in an incredible public health team with a real vast range of experiences. And I think when the data started coming from China right in the beginning, showing 1% hospitalization rates for children, and the proportion of children that were testing positive, for example, to us it was very clear that there aren't many infections where one group is going to be less susceptible to infection as others. And we very quickly caught on the fact that it is most likely that these children are being affected, because if you're exposed to a virus in the household setting and you have no immunity to the virus, it just doesn't make sense that the adult will end up in intensive care, but the child will not even be infected. So very quickly, we were able to extrapolate the data to say, look, children are most likely getting infected, and they are most likely probably transmitting in an asymptomatic state as well. It's just that they either don't develop symptoms or they're so mild and transient that they're not being picked up, and therefore less attention is given to the children. So on that basis, we very quickly started setting up surveillance, not with testing for the virus because we knew we would miss them, but doing a lot of antibody testing. So we went to children of healthcare workers, for example, and look at their antibody rates. And we found very high rates of antibodies, 70 to 80% of them. Parents had no idea that the children had even been exposed to the virus, and yet they had antibodies in their blood. So we could quickly see that children were being infected. They were most likely to be asymptomatic, and they developed a very robust immune response to that infection. And to us, that was a really important piece of information because that also suggested that they could potentially transmit in an asymptomatic state. So straight away, we were concerned that when they go to school and they present with asymptomatic infection, they could pass the infection around to others and then that would take it back home. So very quickly, we set up school surveillance. But again, we went into schools and we started bleeding at thousands and thousands of children and staff to look for antibodies as a measure of infection, not just swabs. And what we found is typically that there were very few PCR positive kids in school at the time. But when you look at their antibody positivity rate, we already knew 5%, 10% had already been infected. And most of them didn't even know they had been ill. So it wasn't the fact that the children weren't getting very sick. We had our role was more how these children will fit into the community, knowing that there's a lot of asymptomatic infection and how they will be able to get on with their normal lives. Because we had no understanding of the contribution of this asymptomatic infection to transmission to others, which is what we were worried about. So
I see.
to answer your question, we weren't worried that they were getting very sick. I think that was very obvious, but we were already planning to understand what part they play in infection and transmission in the community.
I see. That's really interesting. That's been relatively clear to you from the Chinese data, and then your experience early on in England, and so I guess your decisions to close schools, for instance, right early on, I think March or something like that, March, April, the UK closed schools for some period of time. How long were the schools closed for? About?
So no more than 2 months.
No more than 2 months.
I think
okay.
And that was the right thing to do. The whole world was experiencing a pandemic. Schools are part of the community. Based on everything we knew about influenza, transmission, and pandemics, children play a very important role. And as part of the community, at that time when we had no information, it was right to close schools. And the schools were closed between March and May. But the UK philosophy and whatever criticisms you want to make of this government, the UK philosophy has always been to open schools first and close them last. And they have maintained that throughout the pandemic. And funnily enough, we have learned a lot about children and transmission simply because the government has allowed the schools to stay open, even when they sent adults back into lockdown.
So interesting. So you're closed for 2 months, at the time, I guess at some point you started doing these studies on children and healthcare workers to get a sense of what the prevalence was of this in that group, as well as when the schools open again. I guess a few months later in May, you were saying you were doing seroprevalence studies. Can you give us a sense of what percentage what seroprevalence was, or what is your guesstimate based on informed guesstimate? Based on that, and by April, May 2020, how many children, what percentage of children?
So it's really interesting you say that. Again, it was one of those really unusual things. So we work in public health. We don't get funding for this. This is done as part of our core functioning to understand the virus and transmission. There was no big budget studies, no research grants or anything. This was done on a shoestring. And what we did is when we started, I had 5 friends in 5 different cities who found 5 schools that they were going to go into and take blood samples from children to look at seroprevalence when they went back to school in June. And the idea was to have multiple sampling points over time So what you could see is what happens. So in England, we allowed some school years to come in at about 25% capacity between June and middle of July, with a lot of mitigations in place. So it was a really nice starting point. And when the primary school kids came in, about 5% of them had antibodies already. So 5% of primary school kids had already been exposed to the virus before we even shut the schools down, or because they caught it at home from their parents who continued to work. Very strongly associated with health and social care, and with parents who continued to work while the country was in lockdown, which is where they were getting the infections from, not surprisingly. But we also found that the seropositivity rate in the teachers and the students was not that far off. They were very similar to each other, which was really important because that told us what we believed, is that children and adults are probably just as likely to get infected. And the differences we were seeing were due to exposure, rather than because of the fact that children are less likely to get infected, which was the story at the time. We never believed that, because PCR testing of symptomatic people would underestimate childhood infections. Okay. But what was very interesting is that suddenly very important people within the Department of Health and elsewhere realized what the study we're doing. And within a space of 2 weeks, I want to say, we got so much support that we ended up recruiting nearly 130 schools, just simply with the limited staff that we had. So we were literally working 18 hours a day, 7 days a week to try and get the data from all the schools over a 6-week period. And what we were able to show is that if you have smaller schools and mitigations, and you're able to keep community infections down, because the adults were still just coming out of the lockdown when the children went back to schools, we saw virtually no transmission in school, either among staff or among students. Yes, there was a little bit, and yes, there were a few outbreaks, but funnily enough, most of the outbreaks were driven by teachers and the teaching staff at that time.
Right. So it's so interesting that this conversation and your entire focus, and this is so wonderful to hear kind of the bird's eye view of somebody who is doing the research, but it's so interesting that the conversation that you're having then in May 2020, June 2020 has almost nothing to do with how risky this is to children. It's almost entirely focused on schools and whether they are a significant source of transmission, right? Which is what you're saying.
Working towards giving children normality. That was always our aim. Let them be and do their own thing, right, because they are lucky not to be affected by this pandemic. Very different to the swine flu pandemic, right, where we were genuinely, all the clinical trials were in children. We were up 7 days a week doing clinical trials with the swine flu vaccine. We wanted to stop children getting swine flu and transmitting to others. This was not the same. Right. This was about allowing the children to be normal.
In the United States, it was similar, right? I remember I have it was a 4-year-old at the time, was running around still in soccer outside in some camp, and they didn't have masks on. They were playing. They were doing their thing. Schools here were closed, of course, for much longer. They didn't open for God knows how long. But the conversation has nothing to do with the risk to children. And then suddenly it's been surprising. Whatever, surprising or what or not. But I don't know. In the last 6 months, 7, 8 months, at some point, I guess I don't know when. By the summer of 2021, suddenly children. Suddenly there are all these rules about what we have to do to children. As you're saying, there are two things. One is risk to children, and two is, them serving as some type of reservoir, vectors of disease, etc. And now suddenly there's this massive focus on all these things that we have to do to children, meaning masking them, keeping schools closed, etc., to kind of keep them safe. So, what do you think? First of all, and that seems. Did that happen in the UK? I mean, are people in the United Kingdom also terrified of COVID and the risk of COVID to children? And is it affecting policies?
So it's very, very divisive. I think all parents very early on made up their mind whether this is a terrible thing or we don't care. And it's incredible how divisive it is. I think all parents, and what they do is, what I realize is that all parents will go look for the information that will confirm their decision in the first place. So you have very strong proponents of let children be normal, let them get on with their lives, so the risks are very low. And you have the same pushback from parents who are saying, this is not right, my children are not safe. And within that group of healthy children whose parents are really scared, there is a group of those who are children with comorbidities and immunosuppression and so on. And then there are those where there is a family member who's not well and they're worried that the children will be. So there's a big group of children where families where they are very concerned that this is a terrible virus that's going to make them very sick. But that division was always there. And if you look at it, you have to give credit to the hierarchies, be it a mixture of the government, the ministers, the educationalists, and public health workers. But in September 2020, so the next phase was we brought everybody back to school for in-person teaching, which I think was very few other countries did. And we said, you know what? These children are safe. They are no safer at home as they are in schools. It's not that one is completely safe and one isn't. It's just that the benefits of schooling children far outweighs any risks that we might have seen, because we could see that the infection rates remain very slow. And it wasn't that there were any less at risk if they were at home and meeting outside and going to the cinema and so on.
So one clarification, just on that, on the biology. So you discovered that they're not agents or sources of transmission, presumably because they're less symptomatic. Is that the mechanism, or what?
No, we have never said that.
Okay.
Children can get infected and they can transmit. If you look really, really hard, they may transmit a little less than adults, but in a household settings, the better studies that are done with testing everybody, not just symptomatic, and looking at antibodies and so on, that ratio of transmission is not that different anymore.
Okay, that's very important. I'm glad you say that, but then how do you explain, is it the mitigation measures that make it that schools are less...
So it works both ways. Mm-hmm. Yes, so we've just finished a systematic review that was published. And what it showed is that when we look at all the data collected together, the risk in the household is about 10 times higher than in school. Okay. And in the household, adults and children is not that different, which is not surprising. If you are a family of 2 adults and 2 children, you just can't keep away from each other. And children are very close to you. You can't push them away. You shouldn't isolate them. And the virus spreads. And that close and intense transmission does occur in all directions. In schools, the risks are lower because that level of contact is much less. But there's a lot more children. So a smaller transmission rate in a higher population can still count for it. And so they do have transmissions in schools. And yes, they do create outbreaks. And sometimes they take it home and give it to home members. We never said it wouldn't happen. It happens with all the viruses. But the benefits of keeping them in school and everything else that they gain from that far outweighed any risks of them catching COVID. Mm-hmm. And later on, as soon as the vaccine started coming in, we pushed it even further, because then we said, well, even if the children bring the virus to the house, the adults should be vaccinated and they should be protected. And I think once the vaccine came in, it was a complete game changer. And I think then the UK went completely all out and said, you know what, this is the kids can get on with their normal lives, adults can vaccinate themselves, and we are not going to impose restrictions on children.
So getting back to this idea of, because I think one of the big issues has been about how does one communicate the actual risk to children to the wider community. And you described how this was very polarized. People had decided, and it's all about confirmation bias, which I'm guilty of as well, by the way. But did this have anything to do with? Meaning, I'll say what happened in the United States. It appears that there's a big political divide in terms of which camp you go in. Right? If you're conservative, a Republican, you are much more in the camp of, this is low risk to kids. Normality should ensue. On the Democrat side, there's actually a fair number who want normality and have are using this as a political wedge issue and are flipping over. But I would say the vast majority of folks that perceive risk to be, this for children or risk to society from COVID, et cetera, they have this large feeling that the risk is significant. They mostly live on the left, on the political left of the spectrum. Now, interestingly, when the pandemic started, Donald Trump, most famous Republican in the last century, was president, and of course Boris Johnson, who's a Tory, a Conservative Party member, he has been in power as well from the pandemic and in the last year as well. So, I assume the political divide is similar in terms of risk perceptions. Would it have been different if there was a liberal party, somebody on the left that was in power, and if they had tried to say, look, this is the risk to children is low, we should return to normal, would that have helped many on the left?
In the US?
In the UK, no, in the UK.
In the UK, we've always maintained that the risk to children is very low. All the language has been a very low risk.
But the question is, I know, but would that message have been better received by the public in the UK that thinks risk to children is much larger than it actually is, if it was coming from somebody in their party? Yes,
the politicians have a lot of power. And a lot of times, I think that the decisions that come after were basically the justification for what is done usually comes after the decision is made by hierarchies, wherever they are. So those in power have a lot of power and to make decisions, and a lot of them may be personal rather than science-based. And that sort of has driven what has happened. You're right. So the good thing is in the UK, most of the decisions coming from higher up have been to allow children to go back to normal and allow them to open schools. And even, so for example, one of the things that you would say is, well, we know that if children go to school, then you put in as many mitigations to keep them in school, and that will make them safe. But the UK never recommended mask wearing for children in school at all. Teachers could wear masks if they want to. Primary schools were never asked to wear masks ever.
Are there any children that are still alive in the UK after this?
Well, funny you say that, but on a serious note, it just goes to show that the decisions were made. The same evidence base for America, for example, is for the UK and the rest of Europe. And many European countries had children wearing masks in schools, and the US did the same, and the UK didn't. So that decision came from higher up based on the perceptions of risk from those people. So I think we were all in the same place when we started. It's just that the directions that we went were very, very different. And in that way, the UK is fortunate in that it did allow children to go back to normal.
Yeah, and I think what I was trying to get at was that I think a large part of this is political and driven by the politics of it, unfortunately. Yes. And I really think and again, it almost, the politicians now, after a year and a half of saying this is high risk, this is super risky, and this is what we have to do, and you're not doing enough. It is very hard to backtrack, to reverse, and change course. Certainly in the U.S. To do that. Just to throw some numbers out there. This is from a study. Again, everyone needs to follow Dr. Ladani. Fantastic Twitter feed that is just a complete goldmine of information about Twitter that is done in a very data-driven and balanced way, I have to say. But you just recently quoted a study of children and young people less than 18, and tried to quantify the risk of death in this group of folks. Part of the difficulty of that is that there's, in the US for sure, there's so much testing that there's a ton of incidental test positive folks that are having tragic outcomes, but it's not, the tragic outcome isn't because of the positive test. So if you specifically look at children and young people in England, of 12 million children and young people living in England, this is less than 18, 3,105 died. This is between March of 2020 and February of 2021. There were 61 that were positive for SARS-CoV-2. Of those deaths, 25 were due to SARS-CoV-2 infection. Mortality rate, the mortality rate there being 2 per million. So here you're showing that, of 61 deaths, only 25 of those are directly from SARS-CoV-2. And that doesn't even get into the fact that, the significant portion of those who died are not young, healthy children, right? So that type, those are the numbers, right? And those are the numbers, and you've lived those numbers for the last 2 years. Yet you have folks that are still demanding significant amounts of, not normal things in children's lives, whether that be keeping the mask, keeping schools closed, not allowing them to go to, dances, all this different stuff, Again, why do you think that that's still happening? Is it too much TV being watched?
So it's more than that. I mean, that
Yes.
was such an important side. So this is the first 12 months of the pandemic.
Yeah.
Yeah. We had the original wave, we had the alpha wave, and we only found 25 children who sadly died. And every death is unfortunate, yeah?
Right.
But even within that, when you look, 60% of them had life-limiting conditions. These are children who are already in a bad place. And, one of the things that I don't think has been appreciated is that we've had 200 to 300 fewer deaths during the pandemic in the first year compared to the normal year, because there are no other viruses at all.
Right.
And I think what people, and this is a difficult message to get across, is I think what people don't realize is that actually we are so focused on COVID that we forget everything else that's going on out there. And so the biggest message was actually in the pandemic, fewer children have died than they would otherwise have died. And unfortunately, because SARS-CoV-2 was the only virus around, some children who might not have made it because of the other viruses were catching COVID. So even within that group of children that sadly didn't make it, if you look at the context of it, the excess death in the elderly, for example, would be unacceptable because those would never have died. We never saw that with children. In fact, we saw a reduction in deaths during that period. Instead, what we saw is a lot more mental health issues. So even when covering the wards, we were having so many children who had mental health problems, who weren't dying, they weren't committing suicide, they were just seeking help because of all the issues of social isolations. And I think that is the biggest legacy that this pandemic is going to leave for our children, unfortunately, because it's going to be very long lasting, and I don't know how much of it we will be able to recover.
Yeah, the collateral damage just seems to be very, very large, and I mean it's hard to quantify, but certainly it seems to be very significant, and will grow. Unfortunately, may grow over time. What do you think about? So, given all this, what do you think about the vaccination debate in young children? Right, the vaccination debate in young children in the United States. I can't speak to the United Kingdom, and I hope you will speak to what's going on there. But in the United States, there is a fair number of folks that believe, this is such high risk to children, right? I think Anthony Fauci and some other folks were out on the cable news channels talking about the Omicron wave, how it may affect children, how it could sweep through children, how most of the infections may be happening in the children that aren't vaccinated yet, and so therefore, now we are pushing. I think it's fair to say that the public health in the United States is very strongly pushing vaccinations in this group of of young children. How do you feel they've done in terms of convincing or persuading parents to vaccinate? You're a vaccination, and this is what you do. So how do you think they've done so far?
Again, it's a very, very good question, and the problem is it's all about personal risk. Okay, it's what you think is acceptable risk for you. So for me, I have two young daughters, and having seen what I've seen, I was never concerned about COVID and their health. So they never, not once during the pandemic, did they ever feel that their life was at risk in any way, or they were going to get sick with it, or they should avoid catching the virus because something bad will happen. Because they saw what was around when we were having conversations at home. They understood that this was a virus that was causing a pandemic, and that children just happened to be there, and it isn't really about the children. And yet there are many other children who are very fearful for their own health because of the messages that have been given. And there are families that are concerned about the family unit and bringing the virus into the house. And they will go to extreme measures of social isolations or extreme masking so to protect themselves and the children. So it's all about the personal risk, and it's very hard to quantify that in any way. In terms of the vaccinations, one of the things is we talked about deaths and how uncommon they are, and they are ridiculously uncommon, as you can tell. But even when you look at hospitalizations, which is a really good marker of disease severity for adults and the elderly, and it's constantly used to justify or to measure disease outcomes with a new variant or with vaccine and so on, because if you're in hospital, that's a bad thing. Now, what happens in kids, and the data are very, very sparse, is that hospitalization in kids is not necessarily related to disease severity because of such a high rate of incidental infections. If you just measure how many children have the virus and go into hospital within 14 days, you get something like between somewhere around 0.5% to 1% of children will end up doing that. Yet we know on the front line that about 75% of them are not there because of COVID. They're there because every child who comes into a healthcare setting gets screened for the virus, and you're going to pick up a lot of viruses. And the proportion that actually gets sick is very, very tiny. And the proportion of that ending up in ICU is also extremely tiny. And the proportion die, you can count on your fingers. So we know that across the spectrum, even if you are in hospital, that's not a bad outcome for SARS-CoV-2 infections in the vast majority. So the difficulty then arises is, what are you measuring against? And I think one of the most difficult things that has been taken away from all this is, if there was a cost effectiveness analysis that we do for all our other vaccines, where you put a value of cost on the quality of life years that you have prevented with vaccination, I don't think children would ever get vaccinated under any circumstances at all. But when you have a government that says the vaccine is free, we don't worry about the vaccine price. What you have in comparison is the direct risk and the indirect risk. And the direct risk is minimal because it's not, I mean, you do get reactogenicity with the vaccine, but you do it with all the vaccines, we accept that risk. But there are, as you know, concerns about myocarditis. I don't want to talk too much about it. This is your specialty and you know about it, but there is a concern that there is no such thing as mild myocarditis. If you get inflammation of your heart muscle, it can't be a mild thing. And it could potentially have very long-term consequences, or consequences much later in life, where any damage to your heart muscle could have long-term consequences. And so there is a group that is concerned that we are giving these children a vaccine where we haven't really quantified that risk. And going to hospital and going home in 3 days is not a measure of myocarditis outcomes, because you do need longer term data and you never know what subclinical myocarditis does. So when you look at the balance of risks with the vaccines that we have available, the UK JCVI, the Joint Committee on Vaccination and Immunization, turned around and said, look, the benefits of vaccination in 12 to 15-year-olds is very marginal. And the opportunity costs of vaccinating millions of children do not justify such a program to be placed, because you are taking away resources from something else that might be more useful. And that was the big issue with the teenagers. We haven't even got to the younger ones yet, but the ministers overrode that and said, we're going to vaccinate them because we want to prevent education disruption. And that was the basis of the UK teenage program. It wasn't because there was a decision to provide vaccination.
I see. Do you feel, it seems like, and correct me if you think this impression is wrong, given the very low risk to 99 point some percent of children, it seems like the tactic from public health to get children vaccinated relies on inflating the risks of COVID to children.
Um,
If that is the case, then is that the right strategy for public health to take, scaring parents? Is that the right strategy to take to convince somebody to get a vaccine?
So I just got into a Twitter battle since yesterday for the same reason, where there was a scare tactic being used to push vaccinations. And I think that is, in my opinion, and in the work that I do, I think that is a wrong way to vaccinate people because it erodes trust. When you're inflating something that is not as serious, especially using numbers that are not accurate, you are better off giving the right information for people to make up their own minds and take up or don't take up the vaccine. There isn't a right or a wrong, okay? And every family will make their own risk assessment and decide to, and that is completely fine. What you don't want to use is fear and scaremongering to push vaccines when there really are marginal risk benefits. So for example, look, there is no doubt at all that if you vaccinate a child with 2 doses of an mRNA vaccine, their risk of severe COVID ending up in hospital or ending up in ICU is significantly reduced. We know that. We know it from adults, and it will extrapolate to teenagers and young children. That tiny risk that we're talking about will go down quite a lot. So getting the vaccine will definitely give you that benefit. The other benefits are less tangible, because one of the things that says protect yourself and others, protect education, that no longer holds, because we see very clearly with our data that your protection against infection and mild COVID falls really, really rapidly. And with Omicron, it's down to 20-30% within 3 months. You literally lose that protection of not catching it or not passing it on to others. So any argument that we should vaccinate children to protect schools or our community or family members no longer holds. But so, the big one that the elephant in the room that we haven't talked about clearly is long COVID.
Right, that's what I was just going to bring up. So tell me about long. I mean, so then that is the counter. The counter is, the counter is long COVID, and then I don't want to forget the other concept that I think some strong proponents are using to favor mass vaccination of everyone is, can you hear me? Is relates to this idea of mutants and variants. And will you have more variants, and some more lethal variant will come up eventually?
Yes, so protecting against the unknown, and that's that's a very difficult argument to argue against, because you don't know what tomorrow is going to bring. It's completely true, but so far everything we have seen with the virus would suggest that in children, all the variants have had very low risk. We've never seen an increase in the risk with any of the variants. So there is a possibility that the virus will make it worse, but we don't have any evidence to suggest that that might or might not happen. And before I forget, also PIMS-TS or MISC is the other reason. But coming back to long COVID, I think that we have really done a disservice to our community with a lot of the work that was done early in the pandemic. The idea that any person who has any persistent symptoms, beyond a few weeks of infection is given a term that suggests that a long-lasting or a lifelong persistent illness, I think has done us a lot of damage. And the earlier studies where you go to people and ask them, do you have long COVID because you have symptoms that you may have caught at the time of the illness or after the illness, or it can come up later in the illness, or it can be coming and going, or it can be completely new onset, just opens up doors to a whole lot of noise that is detracting from those very few people who genuinely have really long-term outcomes that we should be worried about. So in terms of long COVID, when you look at the more recent studies, and we've published a systematic review on it recently, the more recent studies where you have cases with controls where you can see the differences between them, the difference between the two groups is actually very, very small. The risk of persistent symptoms in children is extremely low. We're talking in the order of 1% or less. and they get better over time. It's not like they've got it and they'll have it for the rest of the life like we usually get with our other infections. Saying that, there is a small group of children who do develop persistent symptoms, but they are not different to the children that get long-term symptoms from other viruses. There's nothing unique about SARS-CoV compared to other viruses. So chronic fatigue syndrome, for example, can happen with any virus, and it can happen with SARS-CoV-2. The only difference is loss of taste and smell, which is very characteristic of this. And if you look very carefully, that's one of the very few persistent symptoms that is reported across all age groups. And that is genuinely a COVID effect.
Are there any potential downsides to a strategy which we employed to mitigate everyone, even though the gradient of risk is so different across ages? Are there any downsides to that approach? So, and I'm saying that because, you know, we had another guest on, and interestingly, who was talking about this. Interestingly, in Japan, there was this strategy to build immunity among children to protect adults. It had to do with flu vaccines and stuff, but because it was compulsory, there were some ethical issues with compelling young people to get it. So I think they abandoned that program. But as an infectious disease person, theoretically, we're not saying have COVID parties in schools, of course, but if you were entering, say, the summer of 2020 with a large, you know, a group of children, and usually around 25% of the population, having robust immunity to natural immunity to COVID, would that have been long-term a good thing? And then in converse, of course, then the question is asked, the question that must be asked then is that should we have taken a very, very low risk population and hid them from COVID as well as we tried to do early on?
So it's not an unreasonable suggestion. And it would have worked if children were the main drivers of infection and if the vaccines prevented infection and transmission. And that is really, really important. So the UK vaccinates children with the nasal flu vaccine. Even though we know that children rarely get severe influenza, they do. So they do benefit from direct protection. The reason for mass vaccination of children up to primary schools and now secondary schools is to protect the population, because even 30% uptake in that group has been shown to have a massive herd impact. So we do that because it works. With these COVID vaccines, they do not prevent infections. They give you very limited short-term protection against infection. And therefore, after 3 months, they are going to catch the virus. It's inevitable. And it is very likely they will be able to transmit it to others. They just won't get very sick with it. And hopefully the people they transmit it to will be vaccinated and also not get sick with it. But if you look at it in terms of vaccination, look at the reinfection rates were already pretty high with the Delta variant. With the Omicron, it's completely changed the picture. So the idea that you can protect children to protect others, at the moment, you can't even protect yourself with it, because these vaccines are not designed to prevent infection or transmission. And therefore, when you put in, the only mitigations that you can put in is to try and prevent infections occurring in the first place. But then you have to do it forever, because you can't take it off ever.
Right, right. So if it's inevitable that children were going to get ill, why would it have made sense to keep schools open in March of 2020 and allow, what happens to happen, and therefore have this buffer of not vaccine immunity but natural immunity that maybe is more persistent than.
No, so I don't agree that at that stage we could have made those decisions. At that stage, we had to prevent that happening. We had to prevent the spread to understand what happened. And we know who the risk groups were, and we had to protect them. There is this idea that you should have focused more on protecting the most vulnerable and letting others get infected. I think from a public health strategy, that is very, very difficult to do. But when the vaccines came in, that became the game changer, because you use the vaccines to protect those who are most vulnerable And you don't have to do that for everybody. So the argument is use the vaccines to provide individual protection. And I think everybody now has come to the realization that you're better off vaccinating the most vulnerable more frequently than trying to vaccinate everybody all the time.
Dr. Ladani, you're advocating something called focus protection, and in the US we consider it as fringe public health.
It's very difficult to impose because you can't, and I'm not imposing fringe. So I'm not saying keep all the elderly isolated and don't let them out of their rooms.
Right.
I think we've moved away from that. I think early in the pandemic we had to do everything to protect everybody as a population. But I think when the vaccines came in and we can see how well these vaccines protect the most vulnerable, what we can then do is say, well, we don't have to rely on other people protecting them. And therefore, we can allow the rest of them to get on with their normal lives. That's very, very different. So even during the alpha wave, where the vaccine was working very well and there were very few reinfections and you didn't really get infected if you're vaccinated, at least early on, there was the idea that if you vaccinated everybody, you will protect the population. But given that what we know now, that even after vaccination, you can still get infected and transmit it, then that philosophy has to completely change. Now it's all about self-protection through vaccination for those who are most vulnerable. Right. And that's very, very different.
This is excellent, really. I just want to dwell for maybe a couple more minutes on this question of transmission within school, which I find puzzling, because you say that kids can transmit to adults at about the same rate as adults can transmit to kids, and
in a household setting.
In a household setting, correct.
Yes.
And the reason schools are schools can transmit and you can have outbreaks, but it's not a major thing. At least it's not like the flu, perhaps, right? It's not like the
yes.
flu, and but the mitigation measures. I mean, if in the UK you haven't been using masks below a certain age, right? I mean, so masks. All the mitigation measures, to me, at least as a layperson, sounds like they're going to be mostly theater, because you're going to have kids on top of each other and so forth and whatnot. And so what do you think accounts for this relative lack of transmissions outside? Maybe if it's true for any setting outside of the household, then it's the case that restaurants also and businesses and places like that are not going to be, except sporadically for reasons that we really elude us, right? I mean, the outbreaks maybe elude us still to this day. I mean, what really causes a true outbreak? Is that fair to say? Or
so again, these vaccines don't prevent infection or transmission. So the idea that you have your vaccine and you can walk into a restaurant and you won't be infectious or infected is rubbish.
Right.
It just doesn't work. And the idea that you wear a mask to your table and then as soon as you sit down, you can take your mask off again has no biological sense at all. But that's a separate adult problem that isn't relevant here. But in terms of kids, when we did remove all mitigations in September 2021, we saw a lot of infections in school children. And that's partly because of the messaging that, look, we have no more mitigations, and they started behaving normally. So we saw very high rates of secondary school infections. And right now with Omicron, up to 1 in 8 primary school children have got the virus.
Okay. But is it coincidental? Is it because of you remove the mitigation measures, or is it coincidental with the fact that there was this new wave in September? I mean, I don't know how it was in the...
So it's both. So from September 2021, we removed all mitigations.
Right.
We saw a huge wave of cases in secondary school students in the first half.
Okay.
And then in the second half, we saw a huge wave of primary school students. And then it's sort of settled because of Christmas, and it's come back with Omicron. And we know that between 10 and 20% of our Omicron cases are reinfections. Mm-hmm. Even in kids, we are seeing reinfections. So it comes back to the argument that whatever you had done, if you get a new variant, it just means you're going to start from scratch again. And the UK has continued to maintain that we are not going to count cases. We are done with
Yes.
counting cases.
Okay.
We are going to look at hospitalizations and fatalities. And so even if infection rates go up, there are no intentions of bringing in mitigations to control this. And one of the arguments, the simplest way I can think of is, if you have mitigations in schools and you have cases coming through at a small rate, at a slow rate, then you will continue to have that for a very long time. And therefore, every time you try and take the mitigations off, cases will go up, and then you have to bring mitigations back in, and then you have to continue. And whatever you're doing will have to go on for a long time. And the UK, like in adults, said, you know what, we don't want them all to have it in winter. So we let go of all our mitigations in July, and we had very high case rates between July and December last year in adults. Mm-hmm. And we never had the massive winter peak that most of Europe saw, because our cases were spread out over the 6 months. So the philosophy seems to be that allow the infections to occur, but then they will settle, and then we can get back to normality quickly. And whether that is a right philosophy or wrong philosophy is for other people to decide.
It sounds pretty reasonable to me, at least perhaps more reasonable than what's happening on this side. And do you have any contacts with counterparts of yours in the US? And do you compare notes? And can you explain why the attitude seems to be so different?
I mean, we constantly have meetings with other parts of the world, including the US. And it's again, the US is very focused on personal risk compared to the UK, where we tend to look at population and public health risk a lot more. It's just the way we've done things. So even if you look at your vaccine programs, for example, if you look at pneumococcal vaccines for children, the US is probably the only country that gives you 3 infant doses with a booster, because that gives you the best personal protection to your child. The rest of the world gives 2 + 1, because the slightly lower risk, personal risk of getting pneumococcal disease is balanced by the herd immunity that you've created with the vaccination program. So that is far more important, because by reducing 1 dose of vaccine, that the resources that you use for that 1 dose can be used somewhere else with better effect. Right. And in fact, the UK has gone to a 1 + 1 schedule, because it believes the herd immunity is far more important than personal risk. So even though there will be a small increase in cases, perhaps the fact that we've removed 2 doses from the program allow us to do more with that. And the US would not accept that philosophy, because it takes away the personal risk. And I think it's built a lot of that. A lot of the philosophy is that you have to protect every single child to the best of that child's ability, which is not necessarily how the rest of the world thinks.
Right. You know, that's very interesting, because at the same, we had infectious disease vaccine specialist, both Dr. Paul Offit and Dr. Cody Meisner on the show. And Dr. Meisner says specifically that you're right, that at least in the US, the ethics is to treat, if it's going to treat the individual child, and not so much if it's going to, what the effect on the population is going to be. But for him, for the COVID vaccine in particular, it was an argument not to vaccinate, not to mandate vaccines in children, because if you mandate it, I mean, the calculus is not there to protect, to give individual risk, which makes me, everybody thinks that these mandates, at least in the US, I don't think you have them in the UK for children, but we have them in certain states. I live in California, and we have a school vaccine mandate, and that's for to protect the adults, not right, allegedly, which it makes no sense, because we know that it doesn't.
Right. I think there's something very strange going on. I think it's political, because obviously we don't seem to care much about the individual risk of myocarditis to kids. There's some larger, but almost zealotry.
But also, why vaccinate the children and then continue the same mitigations that you would hope to remove because you vaccinate them? So what is the personal gain in vaccination? And what is really interesting is that when I look at the immunization rates for adolescents, it's about the same in the US and the UK. It's about 50% over here. It's about 50% over there, just over, and climbing very, very slowly. So it does suggest that, even if different, whatever political decisions are made, you sort of end up in the same place, because, like I said, I believe that most parents have already made up their mind whether their child is at risk or not. Right. But look, there are vaccines do have a role. They protect you against severe COVID, 100%. If you have an underlying comorbidity, I think that it is vital to be vaccinated, because I think 80 to 90% of the vaccine benefits are in those who have underlying medical conditions, because the risk is not proportionate in healthy and those with comorbidities. And I think what we'll find is that those who have medical conditions will accept the vaccine much more than those who are healthy. And I think that is reasonable.
Right. But the conversation here, it doesn't matter, because literally, if you tell folks that, if you say that, look, your vaccine protects you, they'll say, well, no, you can, if you are unvaccinated, you can transmit to me. And it's like, well, but you're vaccinated. So what is the big deal? Like, no, there's still that risk is that risk goes up. So everyone must be vaccinated to kind of stamp this out. So they're playing.
But the narrative has changed even further than that, because
Yeah.
vaccinated people can still transmit to others.
Right.
It's not like they are protecting everybody else, because the virus has made its own rules up. So this idea that vaccination is going to play a big role in terms of population, it no longer holds. You are taking the vaccine for personal benefits. And I do want to come to this, because children will benefit from vaccination, and some parents will find that risk acceptable, because the risk of MISC and PIMS-TS, for example, also appears to be much lower if you're vaccinated. And at least for the short time that you're protected against infection, your chances of long COVID should also be low, whatever that small risk is. But what we don't yet know is, if you still get infected after vaccination, does that infection then carry a lower risk, or do you end up in exactly the same place as if you were unvaccinated?
Right. Dr. Ladhani, can I ask you about MISC, actually, a question I forgot about, since we have a treat of having a pediatric ID specialist here. What happened to Kawasaki's disease during all of this? Meaning, just for the folks listening, MISC is something that was reported first in the UK, because the UK and Israel provide all the meaningful data on COVID that for the world, because the United States certainly cannot get its act together. But the UK first reported this and noticed this multi-inflammatory, multi-organs, a very inflammatory condition, multi-organ dysfunction. And patients were coming in with this kind of plegic, right? The vasoplegia or whatnot. Blood pressures were low, and these patients were not kids. These kids were not acutely infected with COVID, but most of them had a history of having had COVID. Correct?
Yeah.
So and that's how you all report. You all were the ones who named it and found it, MISC. So.
Well, we named it PIMS-TS. The Americans didn't like it, so they decided to put MISC, which has created another rift across the Atlantic. So, but, it's really funny, because when the first 3 or 4 cases were admitted in a London PICU, I was called into a meeting saying, we've got these kids who are very sick, who've come from the same area, who basically are in intensive care unit and very sick. And we were starting to think whether this was a new virus or a new presentation. We were thinking of enteroviruses and going. It never really figured to us that this was a Kawasaki-like syndrome, because there was a lot of the toxic shock component of it, and these kids were very sick at the time. And you are absolutely right. There are distinctions. I mean, what the easiest way to explain is that you have, in Kawasaki disease, we think it's an infectious trigger that is triggering an abnormal immune response to a common infection. That's what we think Kawasaki is, even though we may not be 100% sure with it. We do think that something triggers it. And there are theories about super antigens and so on from specific viruses and all. With Kawasaki disease, with PIMS-TS or MISC, you have a population where you have no immunity to the virus in any child. So any child at any age who catches a virus is potentially at risk. So straight away, we see that the older kids who are more likely to catch SARS-CoV-2 were getting this. And I think people suddenly realized that Kawasaki is for very young and the MISC is for the older kids, and they started teasing out the differences to see that it's 2 different conditions. And then there are studies looking at comparisons and so on. But one, I think that people don't think about Kawasaki now because they're putting it as PIMS now, MISC, because it's such a common condition. And the other thing is that the social isolations and all that have virtually removed all the other viruses or potential triggers. And so I think it's really odd that we don't see as much Kawasaki disease. And it may be that it is underreported or misreported, or the fact that actually the triggers of Kawasaki disease at the moment haven't arrived, and that, because we're not back to normal yet. That's my suggestion. And what is really fascinating is that the risk of MIC has actually changed with the different variants.
Yes, right, exactly, because it was this very tightly linked thing in the US, and for the longest time, it was somewhat scandalous to those of us who follow it, that MISC reporting kind of disappeared. The CDC stopped reporting MISC, and then suddenly 6 weeks later, you saw this MISC wave coming in after the winter wave that we had in children. And it appears to be, decoupling somewhat. Is that is that true? And what would that suggest?
So it's fascinating. So the Delta variant seems to have a lower risk of MIC. And there is a suggestion that, perhaps they've all been infected in the first wave, so they're not getting it in the second wave. But actually, reinfections are very uncommon with the Delta wave in children, at least. And so that doesn't make sense. There was enough of a pool of children who were still catching their first infection with Delta. But what we see even in the UK is a very clear decoupling between cases and MISC with the Delta. And the immunologists have these fascinating theories about how these mutations in Delta actually alter the structure of the spike protein, which then doesn't trigger a superantigenic response and so on. But I don't know whether that's true, but it's fascinating that the risk changes with a variant, never mind a different virus.
Right. Last question.
I have one more after that.
Oh, I wonder. Sorry. Last question for me. Yeah. RSV, a massive non-seasonal spike. I believe in the summer for you, it was in the summer for us, last summer for you as well. What do you think of this concept of immunity debt? Again, with the idea of, how should we be thinking about this when we talk about mitigation measures that may be, hiding children from viruses?
100%. It's a genuine thing. There is an immunity debt, but there are positives in it. It's not all negative. So RSV was one that came outside the season, and we thought we'd have another season with it to make up for it, which hasn't happened. So we don't know what's going on. The modeling suggests it'll be a few years before we get back to normality. So we will gain from that. We're seeing it with bacteria as well. So we saw massive reductions in pneumococcal disease and meningococcal disease. But now that we are removing all these mitigations, we are certainly starting to see increases. So with pneumococcal, you see it in the group with the highest carriage. So with pneumococcus, it's toddlers. And we have seen a 60% increase in toddler pneumococcal disease this year. And with meningococcal disease, it's the teenagers who carry the meningococcal bacteria. And we're seeing a 60% increase in teenagers with meningococcal disease. And the argument is that we have 2 years of susceptible populations who haven't had it. So it's going to be more than 100%, but it never gets to 200%. And that's the advantage that we get at the moment. That's what it looks like. And the other thing is that the other advantage is that getting RSV when you're 1 is much less severe than if you get it at 6 months. So actually, even though you have an immunity debt, catching some of these viruses a bit later may actually not be a bad thing. So there is an immunity debt. I expect that it will cover a little bit of it over time. But I think that it won't make up for the totality of what was missed. So it's not necessarily a bad thing, but we definitely need to be aware of it and make sure that we prepare for it so we can manage them when they come along, like RSV off season, where you do have to accommodate that.
Right. I guess when you think of the whole flattening the curve and protecting the health system, immunity debt factors in there, right? Because you suddenly have this large group that has not been exposed to anything, and suddenly all of them are getting sick at the same time. And in terms of
at an odd time, out of season, when you least expect it, and that's the other thing that we don't account for.
Right, exactly.
My last question is related, but it's more about just basic. So now I think it's been demonstrated. I hope it's no longer controversial that natural immunity to SARS-CoV is more robust than the vaccines. What was the thinking in the vaccine world about natural immunity in general, before COVID, to other things, I mean, isn't there a presumption in general that natural immunity is stronger? It's a genuine question. I don't know for sure, but
Yeah,
what's the...
look, it's a very, very difficult question. I think
Okay.
if you sit back and think about it objectively, coming out of the whole thing, and if you were only had to do one thing, you would vaccinate over 70s and leave everybody else alone.
Mm-hmm.
Because this virus generally is not severe the younger you get.
Right.
Yeah. So what we have done is our acceptance of risk has gone down, has changed over time. And so it's very difficult to put that into context because the vast majority of healthy adults and children will get the virus and be protected and have some natural immunity. And yes, it does give you protection, but so does vaccines. But vaccines wane in terms of protection against infection, but their ability to prevent severe disease and death remains very high over a long time. And I think the answer is a little bit easier because if you're vaccinated and infected, then you have the best immunity of all. So I can cheat by telling you that actually having both is better than having one or the other. But given that we have variants that actually bypass both of them, I think they're both in the same situation. In children, we are seeing that at the moment, more than 90% of our teenagers have antibodies, either natural or vaccine. More than 60% of primary schools will have antibodies after the Omicron variant. We're reaching a point where the whole population is going to have immunity from one or the other. So it'll be interesting to see how that pans out because it's all to do about durability of the protection that we get.
Wonderful. Dr. Ladani, this has been so fantastic. I mean, so the points you've made, vaccines across all age groups reduce risk of severe disease, that you've said multiple times. So whether you're young or old, it's just that that absolute risk is a lot smaller in young, healthy children than it is in other places. And that's why I think, you've said that this really is a personal decision and about personal risks and stuff. The other point you've made really well with data, not just tweeting opinions like me and Michelle or I'm apt to do, is that you've gone out and tried to quantify the risk of COVID to children, both in terms of the acute infection and what it causes, and that risk is incredibly low. As you also said, we have the numbers there in terms of the number of children that gets severely ill with COVID is very, very low. You have published a lot of data on long COVID, and again, showing that the vast majority of children that do get SARS-CoV-2 do not have long-term persistent symptoms. When they do get symptoms, they largely, almost all of them recover. There's a very small fraction that, do require care, and we shouldn't dismiss them. And then you had a whole host of other fantastic things to educate us. So people should get CME after listening to this. This is awesome.
Well, you couldn't have said it better. That was an excellent summary of where we are with kids right now. Thank you.
Fantastic. All right. Thank you so much, Accad.
Thank you very much.
Thank you.